Go ahead and start. I'm going to get on the radio. 35 New London. I've got one something out of the water. We're initiating CPR. There's still one out there that we can't see. We need a rescue boat and an ambulance. There's no breathing. Give 2 breaths. There's no. She's in VFib. We need a shock. Everybody clear? Shock delivered. Start CPR.
1, 2, 3, 4, 5, 6, 7, 8, 50, 60, 70, 80, 20, 1, 2.
So you want to check for breath zones?
Good. 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 Absent. 2 placement sounds good.
너무 내려온 것 같은데? 엑셀러리 맞아야 되는 거 아니냐? 좀 지져야 되겠다. 너무 마른 것 같다고? 그렇네? 조금만 내리갈게. 누가 백보드를 잡아야 될 것 같아. 아니야, 환자가 내려갈 거야. 됐어.
스타트. 너가 인터뷰 할 거니? 준비해줄래요? 인터뷰?
제가 하고 있어요. 잠깐만, 나 미안해.
마리모로 침대 준비.
내릴게요. 네. 55분으로 가서 준비해요. 네? 아, 지금 아직 안 오셨다는 것 같은데?
Go ahead and start. I'm going to get on the radio. 35 New London. I've got one something out of the water. We're initiating CPR. There's still one out there that we can't see. We need a rescue boat and an ambulance. There's no breathing. Give 2 breaths. There's no pulse. I'm going to go ahead. She's in VFib. We need a shock. Everybody clear? Shock delivered. Start CPR.
1, 2, 3, 4, 5, 6, 7, 8, 50, 60, 70, 8, 20, 1, 2.
So you want to check for breath zones?
Good. 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 Absent. 2 placement sounds good.
Ready?
Help.
No pulse. Keep the defibrillator ready.
I'm going to shock and beat. 1, I'm here. 2, you're here. 3, everything here. I'm shocking.
One and two and three and four and five and six and seven and eight and nine and 10 and 11 and 12 and 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
How you feeling? All right, you can go. How much? I gave him 60.
Oh, no, they're not going. He said to stop, so that's why I moved in.
You wanna?
Oh my God.
Yeah, please. Thank you. Okay. Well, you don't we're gonna have to talk to him again. Go ahead. You wanna give a little bit more? No. Go ahead. Clear? Yeah. What is here? 80? Coming out to there. Go.
Yeah.
Okay.
Emergency department management of atrial fibrillation is changing. In the past, the emphasis has been on simply controlling the patient's heart rate. Today, the emphasis is on not just controlling the ventricular rate, but also on converting the rhythm from atrial fibrillation back to normal sinus. This applies not just to unstable patients, but also to stable patients. Most patients who are converted from atrial fibrillation to normal sinus rhythm can be discharged from the hospital. For elective ED cardioversion, the patient episode of atrial fibrillation must be less than 48 hours duration, or the patient must be on some form of ongoing anticoagulation. To begin the process, the patient is placed on a cardiac monitor and an intravenous access obtained, just as with any other cardiac patient. The discharge is delivered through stick-on pads in most patients, although the normal paddles can be used in patients if these pads are not available or do not fit onto your cardiac monitor defibrillator system. Pads are placed generally in the anterior portion of the chest over the sternum of the chest. Synchronized function on the monitor defibrillator is activated and usually indicated by a small marker over the QRS complex. This allows the system to determine when the shock should be delivered so it is not administered during the vulnerable part of the QRS complex, which might result in the production of ventricular fibrillation. The patient is sedated with any combination of procedural sedation agents. In many instances, propofol is selected.
Now I'm going to demonstrate the skill of synchronized cardioversion that our monitoring cables are plugged in and that the 4 limb leads are on, and so they're plugged in, and that they shock someone anteriorly method. And for patient order, remember, not successful. You had time, this would synchronized defibrillation, which could send them into ventricular fibrillation, which is not what we want to do. So, we hit our sync button, and we see the little green light going, and what we see, hopefully, is the little triangles marking all the tops of the R waves, and in this case, it's working quite well. It won't always do that. Pushing the selector knob, pressing it again to select a lead, and then look, and lead 1 looks, recognizing any of them, so we don't want that. See? Our patient delivered, we want everyone go so you can capture run say, and I'm going to push and hold my shock button so everyone's clear of the patient. I delivered my shock, and we can see it was unsuccessful, so it didn't do anything. So in order to re-shock, I'm just going to turn this print off for a second. In order to re-shock him, you'll notice it's in asynchronous mode. There's no more. It's marked to give them another energy setting. Let's say that was 150. I'm going to charge, and I'm going to print while I do this. And I'm going to push and hold the shock button, make sure everyone's clear of the patient. Push and hold. Shock is delivered. And we can see we've got a nice conversion there. So we want to check that, check our ABCs and make sure that the patient doesn't have, in fact, have output. Like I said about
beep, beep, beep. Hi guys, this is our last operate and goes to the ECG points, and they are labeled left arm labels that are white, where we had a patient out in the hospital, specialized care used for different. So back to our monitor here. Just push the green button, and it's going to tell you what to do.
Analyze.
Okay. Notice it has an AED mode, and it also has a lead mode. You can select either one. Right now we are in the lead mode. We'd like to say, ooh, that's a pretty ugly rhythm. This patient is in VTAC. First thing we always want to find out is, does our patient have a pulse or not? This patient does have a pulse. Okay, what are his vital signs? Well, he's got a blood pressure of 120/80 right at the moment, and he's having a little bit of chest pain. But he's sitting up and talking to us and just telling us that he's got a fluttering in his chest. So we want to immediately put, let's go ahead. He's crushing chest pain. We need to cardiovert this patient. We're only done when you have a pulse. Okay? Cardioversion selection, the energy you should select, and wide rhythm, and we're going to go to 100 in this instance. Now, because we don't want to accidentally shock anybody in here in the lab, for safety purposes, we're going to go ahead and decrease the joules to 10 or below. Okay, now we need to charge. Whoops, got to charge. There we go. For the person that's running the defibrillator, bed is clear and no one's touching it. And see, it tells you the energy's delivered. Now, we would hope that perhaps, so then we would just run through, and we still have a pulse. Okay. Okay, we're going to go up to 150 this time. Okay, and actually we're going to turn it back down again. Okay, charge. 1, I'm clear. 2, you're clear. 3, everybody clear. Okay, shocking. Oops, okay, so we just cardioverted. And I said the word shock. We sometimes use those intermittently, but they are different things. Have a pulse. Then the patient does not have a pulse. Okay, and for defibrillation, if we don't know what kind of energy our defibrillator takes, we're going to start at 200 joules, and we're going to charge. Here again, 1, I'm clear. 2, huh? Oh, yeah. Okay. You can still decrease it. Okay. 1, I'm clear. 2, you're clear. 3, everybody clear. Okay. So that is defibrillation. Okay. All right. Now, let's...
This demonstration shows how to use defibrillator safely and effectively without adhesive pads. Wires connecting the patient. Screen with real-time electrical signal. energy selection dial, synchronization button and large charging button at side of screen. Ensure your safety by wearing gloves. The position rather than AED. To turn it to AED. For that, when it is switched on to monitor pedals on the patient, it starts monitoring the pedal. Connect red wire to right shoulder, yellow to left shoulder and green at apex of heart. Now you have to monitor through wires. For this, press lead button. If you press 2 times, lead 2 will appear on the screen and it starts monitoring lead 2. Changing the scale. If signal is weak, optimum wave size and scale massaging the patient, ask him to stop massaging and try to analyze the waveform. Decide whether it's shockable or not and ask the rescue. If the rhythm is shockable, now you have to prepare both the defibrillator and the patient for shocking. Make others away and oxygen away. Select the energy by turning dial to required energy level, that is 150 joule at first attempt. Press charge button to make it charged. Apply electroconductive jelly over apex and right clavicle. When charging completed, it starts alarming as follows. Ask massaging rescuer to take hands off. Take one pedal and keep it at apex. Take the other pedal and keep it below the right clavicle. Look around the table to check anyone touching the patient or table. Check the same rhythm persists on the monitor. Press both pedals firmly to the patient and shock the patient by pressing both discharge buttons simultaneously. Immediately ask the rescuer to restart massaging. Keep both pedals on the defibrillator. Continue CPR for another 2 minutes before assessing the rhythm again. For reassessment, you don't have to turn energy selection dial back to monitor position. It will monitor the patient at turned position. CPR.
It's a cardiac arrest. Please continue to massage. Please come and handle the airway. I'm connecting the leads. Selecting the lead, that is lead 2. And selecting the sensitivity, brief period. Selecting the energy, jelly. Hands away. Free flow of oxygen away. Continue to massage. It's charged. I'm going to shock. Hands away. Applying one pad at a time. Second, looking around. No one is touching the patient. Same rhythm. Shock. Please restart massaging. Restart ventilation. Continue to CPR for another 2 minutes.
Alright, so I'm going to talk about the basic defibrillator modes that we need to know here in our unit, and especially when we... And some... You can... To me. Also, if you want to silence, this is the silence button. Oh, it's not silencing, but alarm's paused. Going to defibrillator mode, you're going to use the dial, and you go to whatever joule settings the doctor tells you to. Usually 150 if they're in arrest. 200 is the max. Say if you're doing cardio version, you would still use the manual defib joule settings, but
15 seconds without sign of compressions.
So if we were doing a cardio version, like I said, say for example 100 joules is the first shock. You set it to 100 joules. You have your heart rate up, displayed on the monitor, and you want to sync. Oh, you know what? You want to press the sync button, and what you're looking for is these little white marks above the QRS, and it'll flash sync. And now you know that you're synchronized with the QRS waves, and you're okay to press shock. Then you charge. I'm not going to actually do it. You press charge. It'll charge to 100 joules. then you press the shock, and it should deliver a shock synchronized with the patient's rhythm. Another setting, or the last setting, has been going on with this. You do connected. It works for. You have to have the lead mode. First thing, the screen you side here, and titrate to 80 beats per minute, and then you need to set it, and then you press start pacing. I'm not actually going to press it, but start pacing. Fortunately, I can't the QR screen.
It's every day, bro. What did the C channel?
To get ACLS certified, you'll have to run through a mega code. And in a mega code, you're going to see a series of bad rhythms and bad clinical scenarios, one after the other, and you're going to have to figure out how to manage them. Central to that is analyzing and first relation, the heart, directions. An untreated world, for example, in a cardiac case, you put the paddles right on the heart. But we don't have that luxury in most cases. Most the outside on and electricity. In a perfect world, that would mean a pad here and a pad way back here, sandwiching the heart. You're not going to really have that luxury in a code. So you're going to have to put the paddles here, and I will demonstrate later. A note someone in a how we go about setting is actually placing the paddles and firing the paddles. We'll show later how we go about setting it. A couple things about pads. You can see that the heart, which is, of course is going to be a little bit deeper, when I shock this, the electricity will be able to go across the meat of the heart. When you shock someone, if you use a biphasic machine, you're going to start at you're going to go right to 200 joules. If you use a monophasic machine and they're being phased out, monophasic phased out, you go right to 360. The idea is we don't work our way up anymore. The idea, when you shock, make sure that you're clear and make sure everybody else is clear. You only have to see someone get zapped once to realize, have you giving, you don't. When you do cardio reversion or pads, work until they fire. I'll press all the things. And now, so when you're going this or not, if we're doing a defibrillation, so you select the energy.
Defibrillation. For this skill, you will need an ECG monitor defibrillator. Please note that review and don gloves. Other appropriate patient based upon don gloves. Medication patches from the patient's chest. If you witnessed the arrest, prepare to defibrillate immediately. If the arrest was unwitnessed and bystanders are not performing CPR, initiate CPR, ensuring you and the patient are in a safe environment. Compressions should be approximately 1.5 to 2 inches. 5 cycles of CPR defibrillation pads. Conductive media. Make sure the paddles or electrodes do not touch. Then turn the monitor on. Ensure the cables are attached to the defibrillator or monitor. Select paddles on the lead selector. Ensure that the rhythm is ventricular fibrillation or ventricular tachycardia. Charge the defibrillator to 120 to 200 joules for a biphasic unit, per manufacturer's recommendation, or 360 joules for a monophasic unit. This may vary according to your medical director and protocols. The patient, proceed by stating, after the shock has been delivered, ventilation 2 minutes. Stop and check the rhythm. If the rhythm has not changed, defibrillate 1 time at the same joule setting as before. Then immediately begin CPR after defibrillation.
I'm clear, you're clear, everybody's clear. Shocking now. Relieving compressions, go ahead and get ready for that.
ALS interventions can be established. Follow local.
You monitor the standard ECG or the ECG. These First, we'll cover the standard leads using the 4-wire cable. Attach it to the green port and turn on the monitor. Now the electrodes. You've probably gotten by applying ECG electrodes without skin prep, and the tracing was okay, but more likely than not, noise is going to be a problem. You can save yourself a lot of time by following these basic recommendations to decrease noise. Put the electrodes on the lead wire first before you apply them to the patient. Choose a site with minimal hair, or shave the site. Scrape the skin like this with the electrode backing to remove dead skin cells. Secure the ECG cable to prevent tugging on the lead wires and electrodes. Okay, electrodes are on. Select the lead you want to monitor. If you see a dashed line and paddles, press lead just once to automatically select lead 2. If you want to change the size, press size until you get the size you want, or use the speed dial. Now let's monitor with the therapy electrodes. Clarification patches, ECG electrodes, or implantable devices. Wipe the skin clean and dry if necessary. Shave the side. This one goes on the... Press it down firmly to get good contact. Axillary line. Electrodes to the therapy cable. If you don't see an ECG, you need to switch to paddles lead. Press lead once, and it will automatically change to paddles lead. Only for cable, and it will automatically change to paddles lead. That's ECG monitoring. Remember, the monitor screen is intended...
Hello class, my name is Alex Seaman. We're going to go over LifePack 15. There are many different functions to LifePack 15, which I will go over. First, you're going to turn on Life through a self-progress. Different capabilities of taking CO2 detector. You also have your cuff, which adult and you have shocking the patient, syncing the patient, or pacing the patient, pediatric, and then you have the electrodes for adult patient. 12-lead hookup of the 4-lead EKG right here. When you have the patient all hooked up and ready to go, and all the leads are on properly, tell the patient not to move for a second. You're going to hit 12 lead. You're going to enter the patient's age. You can scroll through and determine what the patient's age is. Hit the center button to hit enter, and hit the sex of the patient, male or female, and then hit enter again, and it's going to acquire a 12 lead. Also, BP time it every year. You can put minutes support. You also say that what kind of report, and you also have the ability to put where you were pacing. After you're going to go to right now, you're going to go through Pacer. It's going to tell you to connect the electrodes. You're probably already going to have that, and then you're able.
Michael. 3 shift check. It's important the clinician does a systematic check of the LifePack to make sure it's ready for road. First off, the clinician will inspect the leads and cables for any damage. The clinician will now check that the machine has the appropriate consumables for the day. First, she'll check if the soft button at the back of the battery pack to light up the LED indicator. Before your shift, make sure there is over 3 bars left. To perform by pushing the options button, and then use the scroll wheel to dial to user test. The LifePack 15 will now perform monitor for the use of a 4. shortness of breath, chest pain, trauma, acute coronary syndrome, dysrhythmias, and syncope.
Danger?
No danger.
Hey, sir, can you hear me? Sir? Sir, can you hear me? Open your eyes.
What happened?
Okay, you just had a loss of consciousness. Okay, you're at home at the moment. I'm wiring from the ambulance service.
Is to perform the following procedure. To make she will also posture the final step in
The life track on you, and I'm going to attach the electrodes to the leads. Okay, so we can put them on your limbs and then
over
on the bony interior. Over grass. How are you feeling, Justin?
I'm pretty good.
Good. Okay, just stay nice and still for me.
And that is the application of a full.
Alright.
To change the volume, turn the speed wheel. To go to the heart rate indicator, push enter. And there you have your volume.
It most definitely is.
Alright.
To change the volume, turn the speed wheel. To go to the heart rate indicator, push details, press op.
Can I grab your last name, please?
Smith. To mark important events, push event defibrillation. At the end of every code summary, name and sex, or the application, and then use the scroll wheel to put in the patient's age and sex. In a 12-lead ECG, the fourth intercostal space, right of the sternum, V2 and V4. And V4 is the fifth intercostal space on the left of the sternum.
Starting CBO. Continue CBO. Starting CPR. Starting CPR. Everybody stand clear. We are shocking. Now. Shock. Starting CPR. And the first day is Christmas. One, 2, 3, 4, 6, 7, and 8. It's AED noise. CPR. And then the G, whatever it is.
Stand back. Analyzing rhythm. Shock advised. Shock delivered. Couldn't have done it without you.
In the first day of Christmas, you will have to be.
Analyzing rhythm. Shock advised. Push flashing orange button now. Seriously, I can't make it much simpler than that. Push the orange button. Shock delivered. Couldn't have done it without you.
No, and we have a cardiac arrest of response. Cardiac immediately. Yeah, no pulse. Analyzing. Do not touch the child. Do not touch the child. Mama kula, iya ba. We got a kid was drowning.